Thank you for the opportunity to present our case today. My background, I'm a vascular surgeon, and I run our fellowship in Cincinnati, where we have both a 5 and 2 as well as a new 0 and 5 integrated vascular fellowship. And here we are in Cincinnati, which is now covered with about 2 feet of snow. This is the view from the Kentucky side, which is where I live and grew up. And despite that, the myths about Kentucky, this is not how we discipline our kids, nor is this our smoke and fire detector. As far as my case, I'll be a little bit quicker here. We were asked to see a patient a few months ago. It was a 60-year-old gentleman who presented with a right hemispheric TIA and left arm weakness. He was admitted to the hospital and underwent his workup, and his duplex showed normal carotids, but his CAT scan showed this. This was the only abnormality in his workup, was this 4.5 centimeter innominate artery aneurysm. What's interesting, as you can see, is on the diagnostic angio that followed, he also has a bovine arch. So I was asked to see him by one of our CT colleagues, and looking at this patient, trying to figure out the goals of how to help him. You certainly want to eliminate the risk of embolic stroke. We want to exclude the aneurysm. We want to maintain cerebral perfusion to both carotids. Obviously maintain right arm perfusion, avoid periprocedural stroke, and if possible, avoid a sternotomy and a thoracotomy. When I researched it, the earliest report I can find was actually in 1951 by Dr. Cooley and Dr. DeBakey, obviously doing open aneurysm repairs. And in their patient they presented, here's a large innominate artery aneurysm. You can see the incision that they used. And at that time, a lot of these aneurysms were due to syphilis and whatnot, and they would go in and remove and ligate the aneurysm. Obviously, something that has a lot of morbidity and mortality with it. And it's interesting; they live in a different era than we do. When I went through and read their reports from almost 60 years ago, they talk about the operation as prior to the surgical attack, which is just a different mentality than we have today. When you look at how things have progressed for aneurysms like this, what would the traditional open would be to put a side-biting clamp through a sternotomy on the ascending aorta, and then do a bypass to the innominate to the left carotid, and then oversew innominate artery aneurysm at its origin. Things have changed also in that now oftentimes for large aortic arch or innominate artery aneurysms, we do aortic debranching, as I just mentioned, and then subsequently go and put a stent graft across the origin. And that can be depicted here, what would occur for a large aortic arch aneurysm or for innominate aneurysm. And this is one of our patients we did this for several years ago. Here you can see the Dacron graft, and here the tag that we placed across the arch of the aneurysm. When we went back to look at the CAT scan, we're looking to see if there's a way to minimize his surgery. And what you actually see is there's normal proximal innominate artery, and here you can see the left common. When we went back and looked at the angio, understanding that typically to determine whether or not you got proximal distal seal, use a CAT scan, the angio also did help to show us what appeared to be normal proximate innominate. And here you can see the origin of it right here. So at this point, we decided to proceed with a hybrid approach. Our thought was we could get this through a retrograde approach, through a right carotid cut down, which we did through a transverse supraclavicular incision. And our goal was to then place a gore limb, which was a 16, tapered down to a 12, and obviously put it in a reverse fashion. And at that time, also planned on doing a right subclavian artery transposition. So we did it through a carotid cut down, although technically we didn't do vertical, we did transverse for the transposition and followed. And here's our intraoperative images. Here you can see the aneurysm. Here's our sheath coming down. Here's the bovine arch and the origin of the left carotid. And here it is after we went ahead and placed our gore endoprosthesis extension limb. You can see here's the right common carotid. And we went on to do a subclavian to carotid transposition. At 1 month, here you can see the CAT scan shows no evidence of endoleak. Here it is on another view of the CAT scan. There's no endoleak. And what appears to be good flow through each carotid. On the reconstruction, this is concerning. We weren't in this area, and it's likely artifact, but to be safe, I went ahead and did a diagnostic angio. And when you look at it from this view, fortunately there's no endoleak, but it looks like, could we have jailed the left common, although we had a good left carotid pulse. And when you took different views in the appropriate obliquities, you can see that the origin of the left common was fine. And you can see here's our subclavian to carotid transposition. He's now a couple months out. Fortunately, he's done well, and I guess time will tell if this will be a durable repair or if this will go on to fracture and break. So with that, I'd like to say thank you and take any questions.